Mr. Cheriot has been a lecturer at the Egerton University, and now he's lecturing in Kericho. He's going to take us through trauma today. And let me welcome Mr. Sisi to start off so that those who are joining will find us on the way. Welcome, Mr. Sisi.
Thank you. Thank you, Chen.
Yes, Karim.
Catherine, Mary, Jen, Ngure. I see Rita Maritim as my student in Kericho. I had seen Lydia. I think she was struggling to get in. So we'll move on. I'm being assisted here by my daughter, Naitwa Faith.
Welcome, Faith.
Yes. I don't know if you can see the slides, huh?
Yeah, the synergy of traumatization on service providers in COVID-19 era.
Okay. You can hear me?
Yes.
Everybody, I guess. I'm sure the others have muted.
Yes, we are muted, but we can hear you, and the presentation is clear.
Thank you so much.
Okay.
Let me thank Kupka for the invitation. And I remember I'm the one who suggested this particular theme, the topic. And why I did so, around April, there was a medical doctor in New York called Dr. Lorna Bryn, who was the director of a Presbyterian hospital in Manhattan in New York. She was working a 12-hour shift. And I think that eventually she also contracted COVID-19. She was treated, and within a short time, she was back to her workstation. She was the one in charge of the ER, which is the emergency room. Within a short time, I think the hospital saw that she was not well, not necessarily medically, but also mentally. And she was asked to go home. I think she felt betrayed, became suicidal, and committed suicide. It was really hurting. So you find people talking about, was this burnout, was this PTSD, was it a mental illness? And that's why I'm coming out with the synergy of traumatizations on services providers in COVID-19 era. Am I talking about doctors only? No. Yeah, most of them are healthcare. But it would also include you guys who are dealing with mental illnesses. It would include law enforcement officers. It would include firefighters. It would include journalists. Let me not go through the list. I think you'll see it later on in the presentation. And I was saying, as we'll see later on, this presentation is actually dedicated to Dr. Lorna because she actually symbolizes and represents most of the healthcare givers, including also ourselves in the mental health. So I want us to move to look at the executive summary of this presentation, because we may not have a lot of time. And basically, I think the major objective where we'll draw our outcomes is actually how this traumatization impact on the healthcare workers and all those people I have listed. And the selected trauma conditions that we are going to look at, I think most of the time we talk about the PTSD a lot, the post-traumatic stress disorders. But there are several, the vicarious traumatization, and we will see later. The secondary traumatization, we will see. The countertransferences that you psychologists and counselors deal with. The compassion fatigue, which does not only affect people because of their professional roles, but also because of their responsibilities within their family setup. There is one that we have not heard a lot about it. It's called the moral injury, and we will explain as we move on. And finally, the burnout. Why did I say the synergy? I am saying when you look at our case study like Lorna, you can see that there is a role that most of these traumatizations actually came in. When I listen to the media in the US, I'm a consumer of the MSNBC news mainly, and they are talking about PTSD. They are talking about maybe she had a psychiatric disorder. These are people that have no professional competence to charge. But when you look at this, and as you will read later, you can see that there was this kind of synergy where the vicarious came in. That is, you are traumatized because of what the others are going through. PTSD, a bit of it there. Compassionate fatigue is there. Counter-transferences tend to be there. Those of you who are counselors, sometimes you tend to identify so much with a client, even to the point where you lose objectivity. And it takes supervision or some of your colleagues who are looking from a distance. Then, of course, what I would say the showstopper is actually the burnout. At the end of it all these other things have contributed. And the moment you get to burnout, I think that is the last straw. So that is the executive summary of my presentation. I want us to capture what are we going to learn out of this. I'm sorry you'll forgive some of us because we are coming from the classroom and sometimes we tend to follow a certain way of doing things. And sometimes it gives you maybe to be a bit boring or whatever. I'm saying by the end of this presentation, you as a participant should be in a position, one, to be able to categorize in terms of the causes, the various classification of traumatizations or trauma conditions. And I think we did mention in the executive summary, you should be in a position to categorize what are these. Number two, be able to identify the common signs and symptoms of these conditions under consideration. I think signs and symptoms are very important in the sense it will help us to actually wake up and say something is going on here. Outcome number three is to analyze the causal factors in terms of the individual and the organizational variables. Are some of these caused on our individual levels? Are some of these caused organizationally in the workplaces where we work? So there is that kind of a synergy between our own issues, how we handle, and also the organization that we work for. Number four is to explain the way this impact on the various services providers and eventually resulting in what we would call professional impairments. You become totally impaired that you are not able to work. And as you know, in this world, even though we are talking about hospitals, they're also being run like commercial entities. And I think we do understand what we normally, you hear people say, use and dump. So it got to the point. Of course, I don't blame the hospitals, but I would not have expected them to send her home, but maybe to look for professional services for that daktari. So professional impairment is very critical. How do these impact on you? And then you become professionally impaired. And I think that is when you become, as I say, in a commercial world, you are no longer useful. Number 5 is to synthesize the risk factors that would create the vulnerability. How do these create vulnerabilities that it will be very easily or will easily succumb? In the same outcome also, we want to look at the protective factors that we can use as stepping stones to build resilience. Okay, so you are seeing the vulnerable factors and also the protective factors so that we can balance out. How do we deal with the vulnerability? We could be high risk, but if we have we launch on the protective factors, I think it will help us. And then I think the last 2 is to create a wellness program. It's called the self-care plan. And also, there is that awareness of the workplace wellness programs. We talk with a lot of our institutions about the employees assistance program. Yes, it is there. Are people aware? Are those also fully resourced to assist people? And you can see even in hospitals, very big hospitals we are dealing with from New York, those didn't seem to be there. So those are the major outcomes that we can, at the end of it, we can learn those outcomes. When I go to the preamble, we are saying the COVID-19, right from the time it started in China, and I don't want to do a lot of reading here because in the interest of time, it was found out that it created or it caused a lot of chronic stresses, distresses, physical, mental health. And from the studies that have been done in the US and China, it was shown that a lot of people were affected. Let's leave the medical aspects of the physical health, but the mental illness. And it touched the communities, it touched the families, the whole society. Mental illnesses, if left unchecked, will leave people depleted, exhausted, and those who are taking care of them will suffer from what we are calling the compassion fatigue, where we empathize too much to the point that they can suffer into burnout and they are gone. I don't want to touch a lot of this. Of course, most of the common mental illnesses were depression, the anxiety, and even suicide. Below, as I say, is this presentation is dedicated to Dr. Lorna Bryn, and below is her picture. I think you can see. Very smart and very active. She worked so many hours, very committed. When she was supposed to leave to go home, she would want to stay back. Imagine 12 hours. She would ask some of us who work in various places, some of us get there after 8, maybe even 9, and we are beginning to leave around 3. This one was going in maybe 6 to 7 or 7 to 8, and she would want to continue. But that is how it was. All of you knew New York was the epicenter of the COVID-19. Now we are beginning with the first category. It's called the moral injury. You are wondering, what is this thing? Why does this have to do with morality or moral? But that's the moral injury. And in bracket is the wounded soul. Somebody who is wounded. You know, when doctors swear as they join the medical fraternity, they take what we call the Hippocratic Oath. But what is happening sometimes in our hospitals, because of lack of resources, congestion, crowding, the issue of insurances, sometimes the doctors feel they have not performed according to their moral obligation. That's where the moral injury came around. Those of you counselors, you understand when you study ethics, the principles of beneficence, what is in the best interest of a client, the principle of autonomy, self-determination of a client. You are going to protect the welfare of a client. You are not going to divulge the information about the client. That's in confidentiality and all that. Non-maleficence, that means you doing no harm. The issue of fidelity, you are going to remain faithful to your profession. This is what the doctors know. Okay. But then when they hit the real thing, with the lack of resources in hospitals, they find out that what they have learned and how they are supposed to behave, how they are supposed to execute their duties is not as what the moral obligation was. So you find them suffering from the emotion of guilt and shame, psychological, social, and spiritual harm, professional impairment that we talked about. The despair gets elevated, and even they become suicidal. Let me apply this moral injury into the medical scenarios. We all understand, and I think as Kenyans, and even people who may be listening to this presentation from the other parts of the world, that there is scarcity of resources. Even you talk of America, the big nations and all that, maybe better than us, but still there's scarcity of resources. That sometimes the hospital you are supposed to go, your insurance may not be able to support you there. And so sometimes you're sent to the county hospital, which may be the health centers in our country here. So there is scarcity of resources. Doctors have to decide who gets life support, who gets an organ transplant. Insurance has said, that is the limit we are going to pay. What do you do? As a doctor, you want to continue, you are seeing beneficial results, but the management is saying, no, we cannot treat. And I think that's not new to all of us. We have seen that. The patient clinician's privilege is violated. I think those of you who study ethics, the third party, whereby you have to write to the insurance, you have to say exactly what is ailing your patient so that you can be paid. Even you as counselors. The doctors know that what I need here are certain specific lab tests, certain drug prescriptions, or I need to refer this patient to a professional or a consultant who can give me better advice on how to manage this. But you cannot, because this patient cannot pay, does not have insurance, or the insurance have certain limits. These tend to affect the doctors, and they have a problem because they know professionally what they should do, but they are constrained and they are limited because of that. And this is what I was talking about, the moral injury. They feel wounded because they feel they have betrayed this patient. And by the way, you know, there are people who would have survived if they were in certain hospitals, if they were in the hands of certain professionals. But because of lack of resources, they may not make it. And that's sometimes what bothers certain doctors because of the Hippocratic oath that they took. Now, in the COVID era, in hospitals, in testing places and all that, there is fear of infection. I did mention that Dr. Lona was infected by COVID. That was work-related. There is that fear. The wards are crowded, even the consultation rooms. There is also lack of quality in terms of the environment where they are working. I'm talking about these worldwide, so that someone in our country or anywhere else may not get uptight. This is happening all over. Surgical masks are not enough. Surgical gloves, limited, all these things, the PPEs. And these are some of the things that make the doctors not able to perform their duties, and even to be very phobic and very fearful. And that, as I say in the moral injury, it will manifest itself in the self-loathing. That means they begin blaming themselves. It can even affect the empathy. These are people who should be very empathetic, but it can go after a certain point, particularly when you become burned out. It will affect your empathy so that you begin developing hatred to your clients, to your patients, even for counselors. So as we are talking about this, counselors, I want you to relate to that. There is preoccupation with internal distress. And this was some of the symptoms and signs that they saw in Dr. Lona. And then you begin condemning yourself. These are the last parts going into the burnout. I don't think I want to talk about all these. There is only something I want to talk about. Okay. Moral injury has nothing to do with the medical aspects of it, but it is a social, it's an economic, and a political issue. It needs public policies to address those things, the way the medical structures and all that. It needs the intervention of the public policies and even lobbying. And in other countries, you could see what happened in America after the death of George Floyd. And you saw how people demonstrated all over. It went after Europe. We are not very good in lobbying in this country. We just accept things and say, that is the cross I have to bear. There is need for restructuring of the dysfunctional healthcare structures in all over. And then there is something called the triage officer, which is done by doctors. Like now, Lona was in charge of the ER. And sometimes she was making management decisions, and yet she is also a clinician. And I think as you read, maybe later on, we are saying there should be a separation of those who are deciding who is going to use the ventilator, who is going to use, uh, who is going to get an organ transplant, who is going to live. in other countries, they say who is going to live and who is going to die. Basically, it's not that somebody should die, but if both of them needs a certain medical intervention and it is only one, basically you are deciding who will live and who will die. Basically, what is argued here on the triage role is that the clinician who is treating should not make those kind of decisions. Let a manager deals with that, so that the doctor can only deal with clinical matters. So that is about, as I said, that's about the moral injury, which we have not really heard a lot about that, but it is basically dealing with your own morals, dealing with your own ethical, dealing with your own conscience, and disturbing you, not because you have done anything wrong, but you know what is right, you know what you're obligated to do in terms of the interest of the patient, of the client, but you cannot do because of the constraint of resources. And now when you don't manage it, like Dr. Lorna, seeing people dying, and she knew if we had this and this and that, we could save these people. But at that time, it was the epicenter. I used to see Governor Andrew Cuomo of New York State, even up to now, still giving press releases every 6 o'clock here. So you know what is right. Not that you are failed as a medical doctor, but they blame themselves morally that I should have done something, but I did not do. And I think sometimes there are certain things we also blame ourselves. You wish you had this and you would have done this. That's about the moral injury. I'm not going to spend a lot of time. Vicarious trauma, as you are saying, it was actually coined by somebody called Palman. It is similar in terms of the effect with the, but on a lower level with the PTSD. But the only issue here is it is not because this person has gone through all the trauma, but has listened to people giving narratives about what happened, what they went through, looking at the pictures, looking at the charts in the hospital, and then sometimes that also, so that's what you call vicarious. Vicarious in Greek means on behalf. You are being traumatized, not because you faced that, but somebody else who is talking to you and also who is your patient or who is your client went through it. And so those things tend to actually affect you. Just like burnout and all this, it takes time. It is not immediate. Let me move. That's the picture of the vicarious trauma. That is trauma that you are getting on behalf. It is not that you went through, somebody else went through, and they are narrating it to you. You are looking at the pictures, which could be graphic. You're looking to the, listening to the story. Now, the second trauma, which is the indirect, it is similar with vicarious. But the only difference between secondary trauma and the vicarious trauma is the time that it takes. As I said, vicarious, it takes quite a bit of time to develop on a person, the effect of the vicarious trauma. Because you have been told this, you have looked at the pictures, it takes a little bit of time. It's more an accumulation of exposures. But the secondary trauma can happen suddenly in one session or experience. So I want you to differentiate the two, the secondary and the vicarious. Now moving on because of time, I don't want to spend a lot of time, counselors, psychologists, whether you are teaching, you are practicing, you are on internship, but you are doing something related to that. You know the counter transferences. We begin transferring services providers, our feelings, our own experiences to the clients, to the patients we are dealing with. And the thing I wanted to deal about here is, and go back to the doctor or like that loner, is sometimes the patient you are dealing with, the client you are dealing with, you have already transferred some of this, what I would say positive, but in the real sense, it's not positive. You begin treating this person like your son, or like your daughter, or like your mom, or like your sister. It's no longer on a professional level. You are caring so much about this person. It's like a son, a daughter, a sister, a mom, a dad. So that when you go home, you're working in the hospital and then you are free, you are now coming to visit this person like a relative. So that those are some of the counter transference. Let's take our classic case of Lorna. I'm not saying it happened, but it could happen that she developed some counter transferences, transferred certain of her experiences to a particular patient or some patients. And I think you counselors, you know, sometimes when you look at all your clients, there's a certain client that tend to cloud your mind because they tend to be so good. There are also certain clients that you almost develop that distaste and the distance. Those are counter transferences. But in this case, I'm talking about a particular patient, a particular client that you're almost treating like your relative, your very close friend. And if something was to happen, that would actually wound you so bad. Because it's not only a patient you lost, but it's like you lost a relative, you lost a sister, you lost a brother because of those counter transferences. And when they all interact, it becomes so serious. I'm trying to move to the next slide. Yes. Now, the compassion fatigue. This is running on empty. And you know, those who are driving or you got to where you are going, you cannot drive if your car has no fuel. Okay. So what we're talking about this is where a services provider, a doctor, a counselor, a chaplain, has this emotional and physical exhaustion, a diminished ability, even to empathize. We have become so close that energy has been sucked up from you because of that caring. Okay. And it happens a lot, as I said, it's not only professional out there, those who are caring. Maybe you have somebody who is on a wheelchair, you are taking care of that person. You have an elderly person. You have a child that may be suffering from CP, and you are caring, and that can actually exhaust you, deplete your emotional and the physical strength. I think I don't want to go into that. We have listed some of the symptoms there that you can read, and I think there is a place where we'll have for all of them where they share. The effects of compassion fatigue, it can bring depression. People can use substance abuse. It can even lead to burnout. I want I think you can see that image. I don't know if it is Jen that is unmuted. Jen, I think all of them are muted. You can see the compassion fatigue. It's like that is a speedometer and it is running on empty. The gauge has come all the way to empty. And that is what happens when we are dealing with the compassionate fatigue. Post-traumatic stress disorder, I don't want to deal with that. I think we have learned of that. And that's why when Dr. Lorna died, most people at that hospital began thinking of the post-traumatic stress disorder. That could have been. I did not talk to her. I would not read that. It's possible. It's also possible it's not true. But when you read this or you get a DSM-5, you look at the 5 symptoms of that. There is the persistent intrusive experiences. That's the intrusion of events. There is avoidance of places, number 2. Number 3 is arousal and reactivity. That's hypervigilance. This is what we are used to about post-traumatic stress disorder with the DSM 1, 2, 3, 4. But DSM 5 came up with the cognitive aspects, which is the concentration affected in the thinking. It goes to cognition and mood, negative thoughts, distorted feelings. I think DSM 5, dealing with PTSD, added this cognitive level. Okay? And I want to encourage my colleagues because sometimes I think DSM-5 came with some controversies, and people said no. There's, and I think there was a task force that was supposed to go and look at it. And I've told people, and you know, it is good enough. It's only a few challenges that were there. And I've been telling you, some people are saying they will use DSM-4 until this is sorted. But let me tell you, DSM-5 is okay. And you keep waiting for DSM-5 to correct that version, you'll be surprised DSM-6 will be coming. So let's continue using DSM-5 because you are not going to quote, if you are doing research, you are not going to quote DSM-4 when there is 5. So I wanted to say DSM-5 actually captured the cognitive aspect as in terms of the symptoms of PTSD. That is the picture of the PTSD and image. Now we move. We are now in 7. Remember, we were looking at the interaction between the traumatizations, the categories of traumatization. Burnout is actually an exhaustion and depletion. And I think it is defined there, state of emotional, physical, and mental exhaustion caused by excessive and prolonged stress. It is overwhelming and draining emotions. I wanted to say on burnout, it's normally related to your work. It is normally related to your work. Now remember all those what we have seen, all those were also work related. But we are saying this one will not just come, it has to be related to work. And there are about 1 or 2 things I wanted to mention. As I said, related to work. Number 2, sometimes you are doing excessive work with no support. Number 2, there is no appreciation. Number 4, you are not involved in the decision making on some of the things that you are doing. It was arrived at by some other people and you are just given, okay? And when people are not involved, so that they feel like they're part and parcel of that. Okay, then it becomes difficult. Burnout sucks the energy. Remember the vampire. It sucks the energy out of you, reduces activity, and occurs over a long time. Burnout is not something that you see this person okay today and then tomorrow. You see this person, what I would call it, it's like you have a slow puncture. And people can tell something is wrong with this person. So it occurs over a long period of time. I think there are certain common denominators between all those other traumas that we saw and the burnout that we have looked at now. Again, I think I had mentioned burnout is normally, because of the difficulty, is a hostile working environment, maybe a boss that actually is very difficult, and you have lack of support, lack of recognitions. And so it leads, burnout also leads to vulnerability to diseases. So that's an image of a medic that I think going through some, I don't want to say burnout, I don't want to say which other traumatization, but it looks almost pointing to that. I wanted to very quickly and I'm checking my, we are getting there. The three approaches of dealing with burnout. I call it the 3 R's. And I want you to note, 1, you must recognize. You remember we talked about the signs and the symptoms and the signals. You must recognize. We cannot go blindly. And if the person is missing it because there have been too much on them, as services providers, as support groups there, we need to be able to be our brothers or sisters keepers. Number 2, reverse. And how do you do that? By undoing the damage, by seeking support and managing stress and distress. There are some stress that are healthy, but we are talking here about the distress. Okay. Number 3, so you recognize, you reverse, and then number 3, you build resilience. Because you are not going to do much when you recognize, yes, you do something about it, you must actually strengthen your base, build your resilience. In fact, resilience is the word now that's very common in this day and era. And that resilience is the ability to be able to bounce back under very difficult circumstances. Resilience. So you have to be resilient. The ability to bounce back after hardship by use of organizational or personal self-care plans. Okay. If you are learning to ride a horse, because you have fallen off, you have to get back to the horse. Okay, you've gotten some scratches, you'll be able to tell someday it was because of that, but you did something about it. Common signs and symptoms, and I don't want to read them. These are very common. They're under these categories of emotional, behavioral, physiological or physical, cognitive, and the spiritual. These are the common signs and the symptoms of traumatization. And they almost cut across, whether this is VT, whether it is PTSD, whether it is the moral injury or the burnout. You can read later. I wanted to, I don't know if they can see this. Is there a way they can? No. I hope you can see. Jen? Oh no, I'm
Yes.
muted. Oh, Jen,
Yes.
you can see that picture there, that image.
Yes, I'm seeing a lady.
It's like driving, eh?
Yes.
And with a passenger.
With a passenger who seems to have a clock, or is it a watch on the face?
That is a bomb. It's about to
Okay.
explode. Are you seeing all those different, the red ones?
Yes.
Those are explosives.
Okay. On the head.
Yes, and you can see it is saying tick tock, tick tock. That means the bomb is what?
Ready to
It is
Explode.
ticking. It's about to do what?
To explode.
Yeah. But you see, this guy is saying what? He's saying, I'm Maroc. The other one is saying, hey, I'm seeing you are going to have a problem. And he's saying, no, I'm Maroc. Yeah. How many times are we walking around? Yeah. In your work services, in work-related, psychosocial services, and you think you are okay. You are not taking care of yourself. And someone is saying, hey, I think this is too much. You're carrying too much. So that I want you, when you get this, I want you to watch it. It tells you a lot. You can see the timing. I don't know if it's 5 minutes left or is it 5 seconds left. It can explode. It is actually emphasizing that we need to take care of ourselves. Additional signs, hopelessness, powerlessness, all that. Poor job satisfaction. You are feeling lack of safety, and trust, alienation from others, loss of faith. Even you are just questioning God, what is this? Now, risk factors, I have listed them. Your personality is another one, and how you cope. Okay, it becomes a risk factor. If you are very poor coping mechanisms, personal history, maybe you have gone through a lot. Current life circumstances, what are you going through right now? And the most important there is lack of social support system. Okay, we saw Dr. Lorna. Each doctor was busy doing their own things, especially when we are very busy. You're only looking at how much you can do. You don't look at yourself. Am I well? Lack of spiritual connection and resources. Work style, I think we talked about a very hostile environment. You are socially isolated. What is happening now? Okay. We are physically isolated. People are losing people. If there was a time people need people, it is now. When they are losing, either to COVID or something else. But you see, there is that rule now. You cannot, and rightly so. The government is saying we need maybe about 15. I don't know what's happening in the rural areas. Family of 6 is sharing one mask. Okay. Because of resources that are not there. So people are socially isolated at the very lowest of their lives. Even these doctors, mental health workers, when they leave workplaces, they just go and isolate themselves in their homes. Depression, mental illness is another risk factor. Sandwich generation, we will see how it is explained. A sandwich generation, here is a mother taking care of a father or a mother and also the children. So you are sandwiched. How long are you going to survive? Loss of faith in the system. What happened to Dr. Lorna? I think it had something to do with that. Now, organizational factors that lower risks, okay? Factors within the organization that would lower those risks we are talking about and increase resilience, okay? Clear policies, fair and consistent application of rules for employees, adequate resources to meet expectations, promoting diverse and balanced caseloads. That Dr. Ilona, I think the caseloads were too much. Maybe our doctors also here are also doing too much, but they have no choice because we don't have enough. Apple leadership that would make appropriate decisions is very important. Recognition is given and employees made to feel valued. Workers, including health workers, counselors, chaplains, police, firefighters, journalists, but more in the healthcare workers, they must feel safe. Let's go to the hospital, the PPEs, the beds, the surgical masks, the gloves, and the general sanitation. There must be open and clear communication, not only issuing communication when there is some problems. Effective and regular supervision. I'm not talking about supervision of counselors here, supervision by those in charge. And some of you are supervisors anyway in your workplaces. Grievance procedures, when there is a problem, does a person have certain procedures to follow to get their rights? Professional and personal development. Counselors there, my colleagues, are we developing ourselves professionally? In personal development, are we dealing with those issues that need resolving? And if it needs personal therapy, so be it. Peer support, is it built into the organizational structure? Okay, I want to skip some of this. Cultural and community resources, well supported, that's within the workplace. Resilience training, these are things that you'll read, they are very clear. Level of intervention, I think I'm saying here, the primary prevention is when there are programs in the workplace and even for yourself that would help to prevent mental illness and promote mental wholeness. That is before any mental illness comes in. Secondary prevention, you detect early, particularly you remember the high-risk groups we were talking about, and intervene. So that we don't wait for the tertiary intervention where you are going to manage full-blown mental health issues. I think if I bring Lorna, our case study here, nothing was done at the primary prevention level. Nothing was done at the secondary prevention level. But they discovered too late, okay? And then they were saying, she is not good for herself and not good for the patients. Wacha aende nyumbani. And you know what happened. We need to use these levels of intervention so that where we cannot prevent primarily, we can capture immediately at the secondary level. We detect very early and deal with it. But if we wait until the level 3, it will be a bit late. This is something that table that I normally use. I developed it, and but it was somebody, I'm forgetting his name, that actually came with it in the public health. I'll remember the name. Now I want you to look at the high-risk demographic professions very quickly as we move. Paramedics, dispatchers, those who are operating the 911, doctors, physicians, nurses, critical conditions units in the ICUs, mental health professions, including you, and the criminal justice system investigators. You think people like Mohammed, Chicho Pevu, Jonah Lanamus, they are affected by the investigations. Forensic psychologists, pathologists, those who perform postmortems, judges and magistrates because they listen to cases, prison wardens. Okay, prisons now is one of the leading, not only in Kenya, but also in Europe, in America, where there's a lot of infection. And that would actually bring a lot of problems for those who are taking care of them. Prosecutors and defense lawyers, police, and even the fire squads, firefighters, journalists, I think we're men, family caregivers, universities, students, affairs, department staff. You people are putting in a lot of your emotions on that work. When there are chaos at the university, when everybody else is running away, lecturers, support staff are running away, you are the ones who remain around to find out what's happening. Okay, so need some care. VT ways, that is vicarious traumatization ways of exposure, listening to traumatizing narratives, looking at the videos, graphic materials, and the reviewing of case files. That's why the government has actually reined in on media, particularly the print media, not to be putting very graphic materials on their top pages. Those are ways. Specific and individual, I think I'll leave this to you. It's just readable, how you are going to care for yourself. And then, again, personal strategies. Somebody called Michelle, the APC, awareness. What are your needs? Number two, you are able to balance between work and leisure. And then you connect with the resources that can help you. Additional strategies, I'm going to leave that to you. But I wanted to touch this one on joining a support group, not only for support and also to give you problem-solving strategies, but also for validation. When people are going through a lot, sometimes you don't even trust yourself. All you see are weaknesses. But you need people who can validate you and say you are good at this, you really manage this, you deserve credit on this. Okay, so that we only don't tear people, but we show them where they are good. We don't focus on weaknesses, but on strengths. Respite care services, these are services that particularly you are giving people who may be suffering from fatigue, taking care of their relatives at home. You give them a break to go away as you take care of their business, taking care of those who are not well. Not only is that possible personally, but can also be taken to some private homes or professional services. That is the sandwich generation I was talking about. Okay, you have at the top, you have the grandparents or your parents, you are there in the middle, and the children are below. So you are a sandwich. Okay, you are taking care of the parents up and also the children down there. That's what we mean by the sandwich generation. That actually, unless you receive those respite services, you cannot actually lose your mind. Aftercare plan, I think I only want to mention that when you choose a self-care plan, I want to finish by 15 past. When you choose a self-care plan, one, it must be evidence-based. Is it empirically supported? Okay. Not just things you just pick. It must be evidence-based, that it has been proven empirically that it can work. Number two is practice-based. you can see some observable self-care activities, and that they really work. Number 3 is culture-based. And when we say culture here, you might be thinking about the culture of the people, but we are talking about the culture of the workplace. We are talking about the organizational support. Do you have support from the top management so that it can now promote adherence? And also they must have invested resources. That's what I would call the prerequisites of a self-care plan, particularly that is based within the organization where you work. I think justification, why? What is the rationale of self-care? It will enhance physical health and also mental health, manage your stress, maintain professionalism. I think that's important. It is also ethical. Most professional organizations are required. It's very imperative, ethically imperative. That means it is a must that you have self-care. And I want you to read something I put there. And I think also if you touch on that, Dr. Lorna, if your compassion does not include yourself, then it is incomplete. Please, people, take it to heart. If your compassion, you are investing, in fact, it is a noble thing to invest and help people. But it is saying if your compassion does not include yourself, that is being compassionate about yourself, then it is incomplete. And what's going to happen, it will drive you into burnout. Self-aware pulse, that is how you measure life. And I think I don't want to get into that much. The next page, I have left a tool that you can use to measure the compassion fatigue. It can measure the professional quality of your life. It can measure the secondary traumatic stress. And then the trauma and the attachment belief scale. Just play with it. If you Google, you will get some of those tests. And that's when, if you are undergoing some challenges in terms of, is your compassion in the right place? Is your compassion well managed? Or you are going to drain yourself into burnout? So it is there. I think the workplace of professional self-care.
Mr. Sisi.
Yes. I'm
Mr.
listening.
Sisi.
Yes, Jen.
Yes, I think we can divide it into 2 sessions so that we can continue next week.
So we can stop there.
I don't know what participants are suggesting.
I'm okay.
Yes, Jen, I agree. This is a very informative training.
Yeah.
It would be nice, like we go through the self-care
Yes.
one by one, so that we internalize them.
Okay.
So now we probably can get a reaction. If we can get reactions, and then we can continue next week.
So we can stop at the self-care.
My suggestion.
We can. I'm saying.
Yeah. Hello.
I'm saying we can stop at the self-care for today.
Yeah.
Then we can pick it up from there.
It's okay.
Yeah.
It's okay. We can proceed, and then we finish the self-care. Then we proceed next week.
I think after self-care. Hello.
I think you can. Yeah.
Hello. Jen.
Yes, go ahead, Mr. Cheriot.
Okay, from self-care.
Yeah, we can continue with self-care next week, because I think this is very important, and this applies directly to us. We need to internalize.
Okay, so we can stop there.
Yes, then we get reactions from the members.
Thank you.
Hello, members. Hello.
Yes, Jen, we can hear you. Go ahead.
Can we get reactions?
Hello.
Hello, Consolata.
Yes. Thank you very much, Dr. Cheriot. That is very informative session, packed with a lot of knowledge, so that as she says, we actually didn't have time to internalize the very crucial and important information which we as counseling psychologists require, particularly at this time of COVID-19. So it is good we have, as you've agreed, that we have divided it into sessions, so that today we have covered that session, and the next week we will do the self-care, which is crucial. Because when I saw Dr. Rona die, I really felt that she should not have died. Someone should have assisted.
Yes.
And their self-care was missing. Was missing because it is like she wasn't prepared for this, and she didn't know professionally what she was facing. It was very sad that she had to die. Our condolences go to her and her family. So we continue feeling for her. Thank you very much. I don't know whether we have Helen today. Helen, I thought I saw you. And this is well organized as usual. That is you as usual. Thank you very much.
Thanks so much, Consolata. Any other person?
Yes, Jen.
Yes.
Yeah, I want to give some suggestion that I'm happy that I was able to join this conversation. I work with the Ministry of Health, and I'm just whether we can cascade the same to our high managerial level, because COVID has not left anyone out.
Yeah.
President person on the ground. So I think this one was majorly for counselors, but we need it to everyone else. I don't know how Dr. Sheliot and the team, Catherine and the rest of the team, can maybe organize for other members of the members of the health to have kind of conversation. It's very healthy, very interesting. Thank you.
Thanks so much. And I remember in the Kenyan case, there is a doctor who jumped into a running vehicle last week. Was it last week along Kong Road? So it could have been even like the case of Lorna. I saw it in the media, and it was so traumatizing also. So maybe because we'll be continuing next week, maybe I can give it back to our vice chair, Dr. Catherine. Dr. Catherine, can you hear me?
Yeah, I'm here, Jen, and thank you for this opportunity. Welcome. That was also Jen talking. Jen is my friend from the Ministry of Health, and thank you. You could find time to come. We are also doing a lot of work with the Ministry of Health. Jen, this is Kenya University's Professional Counselors Association, and we normally have these meetings every Thursday to build capacity for our counselors and our members who work with the higher institutions of learning in this country. So as an organization, we'll be happy to cascade this to the ministry. So I think we can talk bilaterally and we make arrangements. We will be very happy as an organization to get involved. That would be our role in this pandemic, combating this pandemic as a country. So we are willing, and thank you for finding time to come.
Yes, I think you can crown it all, Catherine, so
We
that
still-
we continue next week.
We can still give, we can still open for members' reaction. I think the facilitation was really very high class and very informative. So members feel free
I'm
to
in our
react.
dinner.
Free to give your input so that Cheriot can also know how to, if you have areas you would want him to cover more next week, things you would want him to expound on, it's your time now to give feedback to him so that he knows where he can put more weight in the next session.
For my case.
Hello.
Hello?
Let's hear from
Hello.
Dr. Musa.
Hello.
Galaxy, let's hear from Dr. Musa, then we come to you. Go
Yes,
ahead.
Dr. Clement, how are you?
I'm well, I'm well. Thank you.
That was very informative, and you have done as well. Thank you. Thank you. Yeah.
Thank you, sir. Thank you.
Galaxy, go ahead. It's your turn
Next.
Hello, everyone.
now. Hi.
Hello. Hi.
Hi.
Yeah, Mr. Cherio, thank you for the good work done. You have brought a very good correlation in situation of our work, as well as the people in organization, like our dear lady Daktari that you have given us as an example. You realize that at a certain point, people are so stuck to work. And maybe because of their interests that keep them going all time. But at the end of it, organization has no value. Nobody recognizes, especially in this time of COVID. Indeed, there's a lot of burnout. And I've seen that even some of our friends, even the children fear them. And yet they are giving provision for the services up to now. Going to work, they come back, and the children cannot hug their parents. They're just like, Mommy, Mommy, how are you? Mommy, bye. Mommy, when will you come back? Daddy, the same. And actually, you have given a very good correlation. But I've seen the ministry has lined out something in as far as all organizations are concerned, that some preparation needs to be done. But now all depends on various organizations, how they're going to pick it up and get prepared for the clans and the people who are working in the organization. It's an eye-opener, and I think next week you can see leaders on, as members have agreed, so that we can be able to go into self-care specifically. In the midst of all this, how then do we take care of ourselves? Thank you, members.
Thank you. Thank you, Consolata. Next.
Thank you.
Okay, hello.
Hello, Jen.
Can I be the next in the queue?
You're welcome, Jen.
Thank you. This was very informative and very helpful, especially around this time. I'm wondering, Dr. Cheriot, if you can add something to do with depression, because burnout and all this that you've talked about, the post-traumatic stress and the others have a close relationship. When you think of suicide, there's also depression that comes with it, and maybe that would be key. Thank you.
Thank you, Jen. Next. Next. Hello. Next. Who is next to give his or her contribution?
Hello.
Hello, Cynthia.
Yeah, I'm Mrs. Ige from Kericho.
Yes.
Yeah, I also want to thank Mr. Cheriot for covering it so well, the effects of COVID on our psychology and that of the service delivery workers. He has done it so well, and I want to say thank you.
Yes.
That's all. Thank you.
Thank you. As you all know, Dr. Cheriot has been a lecturer, a very senior lecturer in Egerton University. He has a lot of wealth of knowledge. So I know he's going to continue next week, and let's be prepared so that we can know how we can take care of ourselves. Maybe let me take it, give it back to Dr. Catherine for the final remarks.
Jen.
Yes.
Okay. Yeah, we'll give Mr. Cheriot to react, then we can close. So go ahead.
I wanted to say, I think Kenya has handled this thing as best. In the government, the ministry, I think there are still certain areas we are looking. But I think when you compare Kenya with some of our neighbors, or even Europe, one thing, I give credit to the president of this country because he has not interfered with the scientists, with the doctors, scientific knowledge that informs this thing. You remember even in his last address, he would have liked to open this country, but there is that science that is still saying something else. If you look at even some countries in Europe, America, I don't want to comment on that. You could see that it has a lot to be desired. I was looking at, when we look at the self-care next week, I was looking at a piece from, I think it was from America. Is it the Zumba dance in Baghdad? It's called Zumba dance, or what? What do you call that dance? Yeah. And they were actually using it as a very classic example of actually decongesting what is happening. So I think they are doing the very best. I think the Ministry of Health, there is somebody, I don't know if it was Jen or who, on the challenges that are there. I think in the medical field and the mental health, I think we can team up together and come up with, ways on how some of these can be dealt with. Let me appreciate next week. Somebody mentioned about depression. Actually, by the time somebody is getting into burnout, actually is going that road. And the suicide rate has been very high, along this line from China. You come to Hong Kong, these other places, Canada, we can see maybe before we start next week, some of those statistics that are actually painting this thing to be something very serious. But I think today I wanted to, so that as counselors, I also wanted counselors who are very, very educated and they can do a lot of research in that. So that when people just say, that one was killed by PTSD, that one was killed by burnout, that one was killed by this, it takes more than that. I don't know if it was Jen mentioning a doctor in Kenya here, almost similar to that. I think it will take quite a bit to know really how has this person been behaving before that happened. So I really want us to be very alert and really sell ourselves as people who are very professionals. And I wanted to say those counselors that are practicing, they get a lot of opportunity actually to put into practice their psychological principles. So I wanted to say thank you. We can meet next week and we pick up from there, integrate a few of those things that people have suggested. Where we'll not be able to cover, we can arrange for another session with other professionals also. Thank you so much. Appreciate it.
Thank you very much, Mr. Cheriot. On my own behalf and on behalf of KUPCA, I want to pass my sincere appreciation. I would like to tell members that Mr. Cheriot actually came out and offered to do this session from our appeal last time. So I would also say that we are open to share the knowledge and the resources we have. So if you have an area you would like to share with members, just get in touch with us and we'll be able to schedule a meeting with you. So thank you very much for that selflessness, the giving. You have shared with us your knowledge, your experience, and we appreciate it. We look forward to meeting again next week. Before then, I would urge our members to continue observing the national and the worldwide guidelines to stay safe. Let us keep physical distance. We said we keep physical distance, but we remain emotionally connected. Let us wash our hands. Let us protect ourselves and take all the precautions as much as we can. And I pray that God keeps us safe and that we'll be able to meet again next week at 3 p.m. So this is a standing meeting. I'll send the link as early as possible. So feel free and encourage other people to come in, other professionals, because together we learn for a better world. You know, we can only take care of ourselves by taking care of others. My take-home message today is if compassion does not include myself, then it is incomplete. So let us try to have complete compassion even as we deal with others. Thank you very much, and let's have a very good weekend and next week as we meet. So kwaherini nyinyi nyote. Keep safe.
Thank you very much.
Please leave the meeting.